Buddy, welcome. Hey everyone, welcome back to my channel. Today we're going to be talking about acute intermittent porphyria. Right, this is a pretty simple topic. Just that it looks a little daunting because the heme synthesis pathway looks a little complicated, but it's really not. You'll see. Now, what is acute intermittent porphyria? Right, acute intermittent porphyria is give me that. The deficiency of porphobilinogen deaminase, which causes upstream rise in aminolevulinic acid and porphobilinogen. The interesting thing to note here is that the carriage of the genetic defect is a lot more common than people that present with symptoms, right? And people, when they do become symptomatic, it happens between the age of 18 and 40, right? The clinical presentation of this is you have to remember that it's episodic, like the attacks will last 3 to 7 days in response to stress, menses, illness, trauma, surgery, and CYP 450 inducers, right? And the enzyme ALAS, which occurs upstream of PBG deaminase, is a CYP 450 enzyme, and the inducers will thus cause an increased accumulation of you know let's say this is the enzyme. If you uh, stimulate it, it will cause increased accumulation of these substrates, and that will cause worsening of the symptoms and could lead to an attack, right? So the usual clinical sequence is going to be visceral, followed by psychiatric, followed by neurological manifestations. So the common term that you will be hearing with respect to acute intermittent porphyria is what we call neurovisceral, right? So in neuro, you want to remember it could be neurological or it could be psychiatric. And visceral is it often presents with it could be colicky abdominal pain. It could be just like non-specific discomfort, right? The most common psychiatric manifestation of acute intermittent porphyria is depression. The most common neurological manifestation is peripheral neuropathy. It can be a Guillain-Barré syndrome mimic, like they can present with motor dysfunction, areflexia, reduction in deep tendon reflexes, and occasionally also seizures and syndrome of inappropriate ADH secretion, which would present with hyponatremia. It can also present with autonomic manifestations like hypertension and tachycardia. And it's also interesting to note that chronic acute intermittent porphyria is not uncommon. We know that it classically presents episodically, but it can also be more of a chronic manifestation. So moving on to diagnosis, it's diagnosed by spot urine test that shows porphobilinogen, the PBG test, more than 6 milligram per liter, and red tinged urine that oxidizes with exposure to light and becomes darker. And then they can do a urine porphyrin screen, which would show elevation of porphobilinogen and coproporphobilinogen. Now, it's important to remember that coproporphobilinogen should not be confused with coproporphyrinogen. That comes later in the cycle. Porphobilinogen comes from coproporphobilinogen comes from porphobilinogen. So these are up here and this guy's up here, and these two are going to be elevated in acute intermittent porphyria. And the testing for PBG deaminase activity misses 10% of cases due to isoforms, like normal isoforms of the porphobilinogen deaminase gene. The normal isoform could confound the results. Now, like I said, porphyrin analysis, it can be done both in the blood and the urine, and mutation analysis would show defect in the porphobilinogen deaminase gene, increase porphobilinogen excretion points to AIP. Like when you're looking to differentiate the types of porphyria, this would be helpful. Increase in porphobilinogen excretion, which would automatically point to this enzyme being deficient. And plasma fluorescence screening can be done to differentiate different types of porphyrias. That's another FYI, you can note that down. Moving on to untreated acute intermittent porphyria, it's interesting to note that it can cause hepatocellular carcinoma because liver is the main organ involved in heme synthesis, which is to say that this cycle is very active in the hepatocytes, and thus the dysfunction of it can cause liver cells to become malignant. And while we're on the topic of untreated acute intermittent porphyria, I just want to finish this portion. It can cause chronic neuropathy and partial paralysis. I already told you that it can present with neuropathy, and because that happens episodically, you would expect the neurological dysfunction to go away once the attack has subsided. But if it's a chronic untreated porphyria, you can expect the patient to come away with partial paralysis where they don't recover function over time. Chronic hypertension, I already told you that it can cause autonomic disturbances and thus hypertension, and it can cause chronic hypertension and by extension chronic kidney disease and of course death, which is just sad. Let's move on to the treatment options. High doses of glucose can be given for mild attacks and hemin for severe attacks. So I need you to pay attention here. ALAS, right? This is the enzyme that we're targeting over here. ALAS, darn it, sorry about that. ALAS can be inhibited by glucose, right? And it can be inhibited by heme and hemin. Like as you can see here, heme is already doing this feedback inhibition kind of thing, so you can give a heme analog which is hemin, and it would inhibit ALA synthase and prevent ALA and PBG from being formed, right? So that's pretty straightforward. And if some patient is having like repeated attacks of acute intermittent porphyria, you want to give them, you could consider putting them on prophylactic hemin infusions. And GnRH analogs can, like guzrelin, can be given for women with menstrual related symptoms. Like I said, menses itself can be a trigger for acute intermittent porphyria. So if a woman starts developing porphyria attacks every time she has a period, that can be very challenging. So you can treat that with guzrelin. Like if you treat them with guzrelin for a long time, that the GnRH receptors are going to get desensitized, and that the circadian rhythm of GnRH, the pulsatility, not the circadian, sorry, the pulsatility of GnRH, if that is hindered, she will no longer menstruate, and thus she won't even have attacks of porphyria, right? So that's pretty straightforward. Now you want to think about pain control. I mean, like I said, they can have visceral pain, they can have constipation, which can be helped with stool softeners, seizure control with gabapentin, beta blockers for tachycardia and arrhythmia, and high carbohydrate diet during the attacks. Like I said, it's glucose that's inhibiting ALAS, so you can give them glucose infusion, you can put them on high carb diets. It's all to do with carbs. So that's why like we saw before, stress and starvation and illness, these are also potential triggers of acute intermittent porphyria. So you can make that connection over here, right? And a liver transplantation can be used as a last resort, because like I said, liver is the predominant organ where the heme synthesis pathway is taking place, and then it's affected very severely. And for patients who have refractory AIP, not responding to a lot of the treatment options that I've mentioned before, they can get a liver transplantation. They would obviously have to get on the list and, all that. Now, givosiran is a new advancement in medicine. It acts by RNA interference. It targets ALAS1 mRNA, right? And then it destroys it. It targets it and destroys it, and lessens the acute attacks in acute hepatic porphyria, right? So if you reduce ALA levels and PBG levels, it's important to know that reducing these two reduces neurotoxicity and mitigates, it also mitigates the triggers for acute hepatic porphyria, right? But the only downside of givosiran is that it's very expensive. It's very, very expensive. I remember reading somewhere around, was it $35,000? I'm really not sure. I cannot seem to remember how expensive it was, but I remember thinking, oh my god, that's really expensive. It's given in the dosage of 2.5 milligrams per kg once a month by subcutaneous route, right? This is givosiran. So that's pretty much it for porphyria. You wanna, go through this table carefully, because this is where the presentation is concentrated. But if and when I if and when I make videos about the other porphyrias, it will be very helpful to go through this cycle. This actually was in New World. That's where I took it from. Very, very important cycle, very helpful to understand the pathogenesis of various porphyrias. It's interesting to note that all of the porphyrias that come from deficiency of enzymes later in the cycle tend to present with cutaneous manifestations, and above a certain point it's going to be neurovisceral. That is something that is a very helpful thing to remember. Early porphyrias present with neurovisceral manifestations, and late porphyrias present with cutaneous manifestations. And I will be tackling porphyria cutánea tarda in another video. I had planned to do that, but not today. Let's just leave it at acute intermittent porphyria for today. I hope that this helped you all. It's pretty simple, nothing to fret about. Just remember neurovisceral, just remember hemin and glucose and ALAS and givosiran, and you're pretty much good to go. Thank you so much for listening. I'll see you guys next time. Have a good rest of the day. Bye-bye.